think that lays a good foundation for Donna's talk. Extensive clinical expertise in managing patients with head brain injuries. And she was the first to develop a neuro rehab clinic in Toronto, which was only the second one in North America. And directed it for 29 years before she founded the head injury clinic at Sunnybrook and St. Michael's Hospital. And she's been with us for 16 years at St. Mike's. And the head injury clinic at St. Mike's is the largest of its kind in Ontario, so it's one of the largest in North America. And so Donna is going to talk about symptoms and symptom recognition. There was a question earlier about people recognizing that they've had a concussion. And so Donna's going to talk to us about some of these clinical aspects. Donna?
Thank you very much for inviting me to the conference. It's been great to hear what everyone else is doing in detail. We're all so busy. I don't know what's going on. So, symptom recognition. It's complicated. It's never just one thing. There are big life changes. Often the athletes are being asked to give up what they love the most. The children are often adolescents and they're going through many things. They're happy to avoid school, and they also have a reaction to treatment. So it's never simple. Goethe says we see what we look for, and we look for what we know. So we need to really have a handle on what should we see. And full recovery is expected at most within 3 months. But we know that at least 10 to 15% go on to have persisting symptoms. And often the symptom recognition is a huge problem. It's not uncommon for us to see in the head injury clinic people who've seen 5 different specialties before they get to us. They may have been referred to a pediatrician, a neurosurgeon, an ophthalmologist, and their own family doctor 2 or 3 times. They may have been tested for infective illness from mono because of the fatigue. So it's really important to understand what we're looking for and to try and put the picture together. So you do have early symptoms, and symptoms that last up to 10 days are considered early symptoms. Again, we run into the definition problem because persisting symptoms within some disciplines are called after 10 days, and within others it's after 30 days before you're called having persisting symptoms. So you see cognitive changes, behavioral changes, and I'm not touching behavioral and cognitive. I think Shri is going to cover that nicely. Fatigue, headache, and dizziness early on. The treatment initially was rest, and this was highly controversial. The rehab physician group were not keen on the rest thing. We felt that symptoms needed to be treated. So this was brought up at the sports concussion group in Zurich, where they have the guidelines, and it was changed. If you look at the new guidelines, and I know a lot of knowledgeable physicians, a lot of physicians who are seeing people now are not even aware of this big, big change. Because initially they were saying rest until the symptoms went away, and now they're saying that rest for 24 to 48 hours, and then take a sensible approach. So if you're doing something that's causing the symptoms, then step back from that. But we're no longer recommending rest in a darkened room. Some people were there for up to 6 months, and we know of some professional athletes who were arrested in darkened rooms with no phones, no video, no TV for 6 months. Late symptoms are symptoms beyond 10 days. And as I said, we define it in the ONF guidelines as beyond 1 month. So the most frequent symptoms that you're going to see are headache, dizziness, fatigue, emotional, behavioral, and cognitive. So headache, 30 to 90% of patients with TBI may develop some form of a headache after TBI, and the headaches can last over 1 year. I've met some professional athletes who are still having headaches many, many years military personnel. We met and treated some of those who were having headaches for a very long time, and then we're just managing them. There are many, many kinds of headaches, and these are defined in the International Headache Society criteria. Migraine, probable migraines, fibrogenic tension are the main headache types. And their ONF guidelines, these are online at Concussions Ontario, and a new upgraded set of guidelines will be out next week. Dizziness. Dizziness is a very disturbing symptom. There are many kinds of dizziness: benign positional vertigo, psychogenic, cochlear, and non-specific. The really important thing is that the benign positional vertigo is very easily treated. People can get rid of their dizziness in one treatment. It can be done in a physician's office, and it can be done by the nurse. In our clinic, it's done by our nurse. In the Ottawa Head Injury Clinic, it's done by the nurse. It takes you about half an hour, but it can completely reverse the dizziness. We've had some very spectacular cases with that. I've seen one with Dr. Rucka, who's the top dizziness expert in Toronto. I'd seen 10 years earlier, and he had not been doing it. He saw the patient 10 years later, and the Toronto Rehab Institute did the cannula repositioning, and the dizziness went away. We had a very remarkable case on the floor here, and they asked our nurse to come up and look at the case, because the case had been sent to rehab with the profound dizziness. They'd sent the patient right back to acute care, saying, we can't do it in rehab, the dizziness is too severe. Alicia went up, did a treatment on the patient, and the patient notified that evening that they could comb their hair for the first time. Even that head movement had been too disturbing, and they went to treatment the next day. So it's very profound, it's very easy to do, and but it does require somebody who's used to doing it a little bit. So treatment, again, is very important. So how do you diagnose it? The good history is important. The Dix-Hall pipe maneuver is on YouTube, and that's the main way to diagnose BPV. And then you need to know whether they've had the concussion. That helps a lot too. So the cannula repositioning, which I've described, which I said is on YouTube, and then habituation exercises are helpful as well. Sleep disturbance. 50% of patients can have sleep disturbance following TBI. Insomnia is the most common form of sleep disturbance. You get circadian rhythm disturbance, and you can get secondary sleep disturbances as well. Fatigue following TBI is a very big problem, and it's found to significantly impact the well-being and the quality of life. It's strongly associated with the somatic symptoms, so the headache and dizziness and pain, and perceived situational stress. So it's important to establish the extent of fatigue and the dimensions of fatigue, and there are good fatigue scales. It's very important to use standardized measures and to use a measure, because if you're just seeing the patient in the office and saying, well, they're pretty fatigued, they're very fatigued, it's not that informative. And it's very hard to talk to other people about the fatigue, and it's hard to show the progression. Other bothersome symptoms that you see are photophobia, which is sensitivity to light. But again, it's really important to treat that. Just pop some sunglasses on them, but you need big wide sunglasses, acknowledge the symptom and deal with it. And photophobia is another one that can last years following concussions and is very disturbing. That one's a lot harder to treat, but again, you can use simple measures like earplugs, noise canceling earphones, and visual disturbances. So basically, very quickly, I've covered the symptoms. So, do you have any questions?
Any questions for Dr. Ouchterlony?
Hi, just a quick question on fatigue. Would you know the reasons, like physiological reasons as to why this fatigue occurs for the people who suffer from sports-related concussion injuries? Would you know, would it have to do with the molecular
using a lot more energy to do normal life activities. They'll tell us, it takes 3 times as long to do something as they did before. So I think that's one factor. I think 2, depression is another factor. And 3, I think there are physiologic factors, and we really haven't got good answers to that yet. So I think it's complicated.
I think you commented on your symptom recognition following concussion. I think you focused more on the first 10 days of symptoms. You mentioned a few things that can last longer. I was wondering if you could comment on the one concussed patient, the recurrent concussed patient, the symptoms and how they resolve or not resolve, so cycling of symptoms. Who any predictive value to developing long-term symptoms? Who's going to have that headache that lasts long with photosensitivity? And then, in my position, family physician, sports doc, the treatment of those symptoms and looking for other causes of those symptoms. So, what is the cause? How do you investigate, or do we have to? So, the management of the, it's pretty straightforward. The acute setting, how to see these symptoms and the denial of these patients, but it's the long-term sort of management of those symptoms.
Thank you for asking that question, because what I do is the long-term management. We see people and manage them for a couple of years. So I think that's a really important question. Investigation, I think investigation often is fairly straightforward, but we're very lucky with our dizziness. We work with Dr. John Rutgers. He comes here once a month. We tease out who needs to see him, and then he does the full dizziness assessment at Toronto General, where he has a dizziness lab. So I think if you have persistent dizziness, you've tried Candlelight 3 positioning, then go on to further investigation. Is the yield great? Like, is it going to come up with something that's really going to change your management? Other than the BPD part, it's hard to say. Headache, I think the most important thing there is making sure that you are treating the right kind of headache. So the one I didn't mention was drug-induced, and you see a lot of that in people who have going on for a long time. But I think, focusing on treating the right headache is really important. I think the migraine experts will say that they feel we're under-treating headaches badly, they'll say. So I think, hit it really hard using, the preventative. The 2 that I use are propranolol and Topamax. And again, get up to really good doses with that. I do all the general stuff as well. I do telling you to eat 6 times a day, exercise regularly, stop all caffeine, look for triggers, do all of those things. So migraine education is important. And then, as I always say, there are the 3 stages, where it's, prevention and abortion of the headache and symptom. And I always tell them we never want to be there. We never want to be treating just symptoms. So treat aggressively with the prevention and the abortion of the headache. So that's the traps and things like that. I think, again, you need a lot of counseling, taking people through all these things. And the photophobia and the phonophobia, I have a case right now, I'm a very highly placed legal professional, and we're on to 3 years, and that's her most disturbing symptom, is the phonophobia. So all I'm doing is, again, simple stuff, earplugs when you're going to events where you can use that, ear canceling, noise canceling phones, so things like that. So, like sleep, always investigate and then manage on an evidence-based way. People who are going to get it, are you more likely to get symptoms with repeat? Yes, you're more likely to get symptoms with repeat. Special groups that are more likely to have prolonged symptoms. They've shown that females, young adolescent females, are more likely to take longer to recover than adolescent males, so there are trends. We're presently engaged, Guzmano, Andrew Baker, myself, Jane is part of that group, in a big database study. We're using all of the assessment tools that are recommended in the Zurich Consensus Guidelines, in the ONF Guidelines, and in the NIMS, which is at the USA. We picked out various tools. We've already entered 58, and we hope after we've got a couple of thousand entered that we'll be able to say, okay, here's a profile of who's going to be vulnerable. I looked at this years ago. I thought that when I first went to TRI, we had, I was working in the WSIB Neurology Clinic, and we had some unusual resources because we could have everybody MRI'd, we could have everybody done in the UHN business lab, and I thought that I'd be able to come with a paradigm and say, if they've got this, and they've got this, then for sure it's going to be shorter, or for sure it's going to be long. Wasn't that simple. So we're using again, a lot of people are saying, look at psychosocial, and we've done a little bit of work on that. We do find the lower socioeconomic group certainly I think they carry a greater emotional burden than a lot of other people. Often they get back to work too early because they have to get back to work. So I think that's a group that has a problem. We're using a measure called the OSU, I think it's called OSI, I think Ohio State University, and that's a psychotrauma measure, because I think that's a group that we probably need to bring extra resources to. So, do we have the answer? No. Are we looking? Yes. We're looking very hard. We hope to have some answers as we go along, but it's going to be a composite. It's going to be a composite. And we're managing many for years. It doesn't go away with a lot of people. And, with the sports people will tell you, the CTE people say, the average 18-year-old who's in multiple competitive sport has had 10,000 subconcussive hits by the time they're 18. So if they get symptoms, are they going to go away? Probably not quickly. It's important to manage them, and that's what the message I try to get across. You can still have a good life. We'll manage the symptoms, and you can still have a good life.
My name is Marcia, and about a year ago, I was involved in an MBA crossing the street at a crosswalk, and unfortunately was hit by a car and suffered a concussion. Of the 28 kind of symptoms that are listed on this little card here, I exhibited 20 of the 28 now, and I have to commend you for breaking down each of those symptoms and really attacking them kind of individually rather than just grouping them all together, because as somebody who has kind of been through it, all of those together are way too overwhelming to kind of tackle. I love your approach with it. The one that you focused on was the kind of positional vertigo, and I'm just wondering, there were 3 other kind of categories of balance and indigenous related things. Can you expand a little bit on some of those and kind of, I don't know, the angle for helping to maybe lessen those symptoms?
Well, psychogenic dizziness means that people are usually hyperventilating, but that's the test for it, is are you hyperventilating and then getting the dizziness. And of course, then it means we need to direct more attention to the psychological state and treat that. And again, I think it's important for the patient to know that that's what's actually causing your dizziness. Cochlear is another part of the inner ear. And I think anyone who's having ongoing dizziness really needs to be seen in the dizziness lab. Unfortunately, in Toronto, it's very hard to get into those things. I know if you're seeing Dr. Radka through regular channels, it's a year before you are given an appointment. Not even that you're going to get in, but before you're even given an appointment. So it's a big problem. It's a big problem. I think, again, one of the important things is if we can get all the BPPs managed, if we can get people to see, okay, here's one aspect, and this can be treated. If you're down in the office, you're going to get really good results. And maybe we'll have more spots for the complicated